inflammation of either sclera, mucous membrane, or skin. Okay, for jaundice to be apparent or to look at someone and say he's jaundiced, then at least this patient has a bilirubin level of 5 milligram per deciliter or above. So any level below 5, it's not something that you can visualize or see. How common is neonatal jaundice? So عم نحكي عن neonates مش عم نحكي عن children ولا عم نحكي عن jaundice in children. So it's a very common problem. So if you take 10 term babies, 8 out of 10 will develop at one point physiological jaundice, which is very common. يعني 8 out of 10. For term babies, the peak of this jaundice usually happens at day 3 of life, and it rarely goes above 12 milligram per deciliter. And it's also a more common problem in premature, and we tend to see that in prematures it's more exaggerated, their jaundice. So if you take about 10, أنا خربطت بالterm 6 out of 10 and 60%. And preterm it's more common, it's more exaggerated. So if you take 10 preterm babies, 8 out of them will develop neonatal jaundice at one point of their early days of life, but it usually peaks later than term babies, so at day 5, and it can reach a limit or a peak of 15 milligram per deciliter. It's important to know the difference between jaundice in terms and preterms, because if you follow them up, you'd expect jaundice to be more prolonged in preterm more than in term babies. Why do we care about neonatal jaundice? Yes, we need to know that this baby is jaundiced, the level of jaundice and the cause of jaundice, to manage it appropriately, but the most important part, specifically for deeply jaundiced newborns, is to pick those at risk to develop kernicterus, which happens as a result of CNS toxicity when bilirubin level approaches or exceeds a level of 25 milligram per deciliter. How is bilirubin formed? So it all starts with hemoglobin heme ring. So this heme gets oxidized by heme oxidase and will be converted to biliverdin, and this biliverdin by biliverdin reductase will be turned into the form that we know, the unconjugated bilirubin. Then UDPGT, which is the uridine 5-diphosphoglycourine transferase enzyme, will conjugate this bilirubin, so it will turn from unconjugated or indirect into conjugated and direct. This direct or conjugated bilirubin, because it's conjugated, it's water soluble, so it is able to dissolve in water. So it goes to the intestine, and then it will be turned by the normal flora in the intestine into urobilinogen. Now this urobilinogen, part of it will go back to start from square one to the liver to start the whole the whole sequence once again, and part of it will get reabsorbed back to the kidney and excreted in urine as urinary urobilinogen. A small amount of this will stay in the intestine, form stercobilin, and this gives the stool its normal color. Okay, so you need to understand the difference between conjugated or direct and unconjugated or indirect bilirubin. So conjugated is water soluble. Our body can deal with it easily. It can dissolve in water, so in intestines can dissolve regularly, and then the sequence of turning it into, for example, stercobilinogen and excrete it or get rid of it through stool is very easy. As well, to get rid or excrete it through urine is very easy as well because it's soluble. However, if it's unconjugated, if we could not conjugate for one reason or another, this will be water insoluble, so your body will struggle getting it out. It would be lipid soluble, meaning that it can cross the blood-brain barrier, and here comes the risk of CNS toxicity, specifically in newborn. So I think you have the old version of the lecture that says unconjugated is not toxic in this table. So unconjugated is a toxic form because it's lipid soluble. Conjugated can be sometimes toxic. القصد فيها إنه if you have overwhelming levels of bilirubin production. So if you are going through hemolysis crisis, for example, and your body can't produce enough UDPGT enzyme to conjugate this level of bilirubin. Part of it will be still unconjugated, even though you have no problem with conjugation, but your hepatobiliary system and liver enzyme is overwhelmed. So sometimes portion of it will become toxic because it is unconjugated basically. How do we classify jaundice? So either according to its underlying cause and outcome, into physiological and pathological, or if it's unconjugated or conjugated or direct or indirect. And some classifications follow the onset of symptoms. So when we say physiological jaundice, the term physiological jaundice refers to something that's not pathological, and there's no underlying pathology that's causing this hyperbilirubinemia. So in order to say this is physiological, of course you have to rule out pathological. So it is a diagnosis of exclusion. So you have to exclude other underlying pathologies by specific workup that we usually do to newborns with high levels of bilirubin. However, we look for clues for physiological jaundice. So you look for clues or specific points to consider. For example, physiological jaundice never appears on day 1 of life. So if a baby is just born and during the first hours of life develops jaundice, this is red flag. So we can't say this is physiological jaundice. We for sure need to rule out pathological, and it is most likely pathological. Why does physiological jaundice happen? So when babies are first born, their circulating red blood cells, their lifespan is shortened. So an average lifespan of RBCs is about 70 days. In comparison to your RBC lifespan, which is about 120 days, meaning there's rapid turnover of RBCs and more frequent destruction, and this means heme ring being broken down and then bilirubin production. As well, when babies are first born, their MCV, MCHC, the RBC mass is increased, so which means more heme, and then again more bilirubin production when this RBC is destroyed. Ligandin is an albumin or protein that carries bilirubin to be conjugated. This ligandin is sometimes insufficient in just born babies. This could be another cause to why they develop jaundice. Some other causes include high activity of beta-glucuronidase in the gut, and when we describe the the sequence of forming direct and indirect bilirubin, we say that part of, if you can see here, part of the conjugated bilirubin is taken or transformed by intestinal flora or bacteria into urobilinogen so that your body can excrete it through urine. However, this process is not very well developed due to immature gut flora in just born babies. The ability of the liver hepatocytes to produce the UDPGT enzyme, which is responsible for conjugating bilirubin, is somehow decreased. This is another reason to why they develop jaundice, and this is totally physiological because with time it goes back all to the normal levels. And that's it. So these are the major causes of physiological jaundice, or why we see physiological jaundice commonly 8 out of 10 in preterms and 6 out of 10 in preterm babies. Okay, we discussed the peak and how it differs between term and preterm babies. Usually most physiological jaundice, when you follow them up, they disappear. Jaundice will disappear after week 2 of life. So after week 2, mostly babies are back to their normal color. However, there's some exception to this. Of course, other factors, as I said, can influence for how long jaundice persists, like, for example, in prematurity. Okay, so we say that physiological jaundice, it has specific patterns, so is pathological jaundice. So pathological jaundice, it has a specific pattern. So If you admit a baby with hyperbilirubinemia or jaundice and you notice that the bilirubin levels with serial checking, because we serially check their blood levels of bilirubin, if you notice that the increment is very fast, so more than 0.5 milligram per deciliter per hour, this is for sure pathological. Physiological jaundice will never cause this quick rise in bilirubin. Also, if you are evaluating a term baby and their peak of jaundice that we mentioned that happens at around day 3 of life, if it exceeds 13 milligram per deciliter, this is uncommonly to be physiological jaundice, because we said in term the peak is around 12 milligram at its most. If you compare the direct bilirubin fraction to the indirect bilirubin fraction, and you notice that direct bilirubin is more than 20% of the total, this is never physiological jaundice, this is pathological. Or roughly, if you measure at any point the direct level and you find it to be 1.5 milligram per deciliter or above, this is pathological by default. If you examine, because any kid with jaundice needs to be fully examined as any newborn, right? So it's because there might be any underlying pathology, so you need to do full physical examination. So on exam, if you find any abnormal finding like hepatosplenomegaly, abnormal skin rash, etc., this goes with pathological jaundice as well. So these are the points that we've just mentioned. Okay, so again, to compare between physiological and pathological jaundice. With regards to the onset, usually physiological never appears on day 1 of life, usually second, third day, and this is not the case for pathological. So we can see pathological jaundice happening just few hours after delivery. So we saw jaundice appearing deeply, like very deep jaundice in a newborn baby who's just 4 or 5 hours old, which indicates for sure pathological jaundice. Again, the rate for bilirubin rise can be a very important hint. So in physiological jaundice, the rate of increment is less than 0.5 milligram per deciliter per hour, and it's more than that in pathological jaundice. As we say, you look at the peak concentration of bilirubin. In term, it rarely goes above 12 if it's physiological, and rarely goes above 15 in preterm babies. But this is not the case in pathological. In pathological, it goes beyond that, and it can reach up to 25 milligram per deciliter, risking the baby CNS. How long does it persist? Most full-term babies, their jaundice will start to disappear in the first week of life, and you rarely see it after week number 2. And for preterm babies, usually it can extend beyond that. But again, for both term and preterm baby, by week 2 of life, in most cases, jaundice will be resolving. However, this is not the case in pathological jaundice, because there's an underlying pathology going on, and unless you stop it, jaundice would persist. So it goes beyond the second week of life. Again, if you at any point check the direct or conjugated bilirubin level, if it should be always below 1.5 milligram per deci at any point in physiological jaundice, but more than this in pathological jaundice. Usually in physiological jaundice baby, the physical exam is normal, they're active, they're feeding well, they're afebrile, there's no hypo, there's no thermal instability, their bowel motion is normal, urination is normal, etc. However, in pathological jaundice, if you do proper physical examination follow-up, you might find abnormal signs on examination, like pallor, for example, which indicates anemia, tachycardia, again, which could indicate anemia. Sometimes they're actually born with hydrops fetalis because of the severe ongoing antenatal hemolysis and low hemoglobin levels. So this table summarizes what we just mentioned with regard to the difference between physiological and pathological jaundice. So what causes pathological jaundice? So we mentioned the difference between both, and we said why physiological jaundice happens, okay? Now, why pathological jaundice happens? So we say that the problem all starts with heme or hemoglobin, okay? So if there is increased production of hemoglobin for any reason, like for example, increased production of bilirubin for any reason. Like for example, if someone has got G6PD deficiency, there's an ongoing crisis, more hemolysis, so more bilirubin will be produced, for example. If someone is born with polycythemia rubra or polycythemia, high hemoglobin levels or high hemoglobin concentration, this means that there is a pathological cause to why more RBCs are being destroyed or destructed. If you remember what we discussed in physical exam lecture, we said that some babies are born with cephalohematoma, which is basically blood collection sub-periosteally, right? And if this collection is very large and there's a fair amount of blood in this collection, this blood will be hemolyzed, and these babies are at risk to develop hyperbilirubinemia, which is also pathological because there's an underlying pathology, which is the cephalohematoma itself. The second reason for pathological jaundice is decreased clearance. So our body can't clear the bilirubin levels, and the causes for this can go long. There might be so many causes, but the common ones, if we're dealing with newborns, like if a newborn is septic, if a newborn has sepsis can sometimes threaten the hepatocyte ability to produce the enzymes, and sometimes sepsis can cause biliary stasis. Okay, so the flow out of bilirubin will be affected, and then the baby will develop jaundice. This clearance can be also sometimes related to rare genetic disorders, so which means a problem with the UDPGT test, like Crigler-Najjar and Gilbert syndrome, type 1 and type 2. The third cause of hyperbilirubinemia is the increased enterohepatic circulation. Okay, by that, when we say there's increased enterohepatic circulation, means that the time elapsed from where bilirubin has first been excreted to intestine, and the time it stayed in the intestine is prolonged, which means, if you go back to this, if you look, so we say that conjugated bilirubin stays in the intestine for a while, during which intestinal bacteria turns it into urobilinogen, right? So if this duration is prolonged, more urobilinogen will be produced, right? So more urobilinogen will go back to the liver. So again, this will be turned into what? Again, it will start the whole sequence. So more levels are accumulating in our body, and less levels are being excreted through urine and stool. So prolonged enterohepatic circulation. Okay. Other causes for increased enterohepatic circulation, what we see in breast feeding jaundice. And one more cause, breast milk jaundice. So these are two separate entities. Okay. Here, commonly, breast milk is physiological, but sometimes we will discuss that later. When breast milk jaundice, it has specific enzyme. This enzyme can threaten the conjugation process and can cause hyperbilirubinemia. Sorry? Beta glucose, yes. Or if there's breastfeeding jaundice should be on the physiological list, not pathological, you're right. But both actually, milk and breastfeeding, yes, you are right. But both can increase enterohepatic circulation, breast milk and breastfeeding jaundice. In breastfeeding jaundice, specifically, we see this in primi gravida or primi mothers. And this is their first baby, and they have no clue how frequent they should feed the baby, how frequent they should wake the baby up, for how long the baby should feed, etc. So sometimes baby can have less amount of milk than they should, and this would cause slight dehydration and will cause hyperbilirubinemia. In breast milk jaundice, it's related to the enzyme beta-glucuronidase that can affect the ability to conjugate bilirubin, and then it will cause hyperbilirubinemia. Sometimes if we have gastrointestinal obstruction, this as well can affect the enterohepatic circulation and the excretion of bilirubin by stool. Other obstructive causes like biliary atresia, so anything that blocks the hepatobiliary pathway to or the overflow of bilirubin. Now, obstructive cause, as I just mentioned, can sometimes be functional, not anatomical, like in sepsis. So in sepsis, or patient or babies with congenital torch or hypothyroidism can have obstruction, meaning biliary stasis, okay? Some babies who have got, for example, any sort of infection and receive cephalosporin, like third generation cephalosporin, this can also cause like stasis or inefficient excretion of bilirubin. Other cause of increased or pathological jaundice, these should be again as part of increased hemolysis. So if someone has got spherocytosis or of any other structural abnormality of the RBC shape, we know that the RBCs should go through the reticular endothelial system, and there any abnormally or any aberrant RBC should be destroyed. So if you've got spherocytosis, the shape of your RBC is abnormal, more RBCs destroyed, more bilirubin will be produced, etc. Some medications can inhibit the conjugation of bilirubin, like vitamin A in toxic levels or in increased levels, and sulfonamides. Other inborn error of metabolism as well can cause pathological jaundice, like what we see in galactosemia, and usually it is direct hyperbilirubinemia. Thyroxine deficiency, well, if you read books, you will find that thyroid disorders can cause both, so it's sometimes mentioned as a cause of direct, sometimes as a cause of indirect bilirubinemia. In my career, I noticed that most thyroid problems cause direct or conjugated hyperbilirubinemia. And the problem with that, with the thyroid disorder or thyroxine deficiency in specific, is that thyroxine increases the activity of gluconeotransferase, which promotes conjugation. So if thyroxine is deficient, this would be decreased. Okay. Now, causes of indirect hyperbilirubinemia, when we mentioned those, hemolysis like ABO or H. So the idea of the slide to know that hemolysis causes indirect hyperbilirubinemia. Okay, so in hemolysis, there's no problem with the gluconeotransferase enzyme, so it's indirect or unconjugated. Okay, non-hemolytic causes like what we see in physiological jaundice and breast milk jaundice. Again, some rare genetic disorder can produce unconjugated bilirubin, like Crigler-Najjar syndrome and Gilbert syndrome. Okay, ABO incompatibility. If a mother is born with a blood group O, what does that mean? O blood group. She doesn't, the RBC does not express neither the A or the B antigen, right? So, she has no antigen, ما عندها A ولا B antigen, and the baby is born with blood group A or B, which follows, for example, his dad's blood group, okay? So, during pregnancy, there will be what we call feto-maternal hemorrhage. Means passage, for example, of baby RBCs to their mom circulation. صح؟ احنا بنعرف إنه المom circulation can have trace of the baby's RBCs, and this is the way the NIPT test diagnoses genetic disorders أو knows the gender of the baby. صح؟ لأنهم بيشوفوا RBC fragments من البيبي in the maternal circulation, and then they do the DNA extraction and diagnostic, whatever they do. So if some of the baby RBC leaks to the mom will recognize this as an antigenic cell. So the mom will start producing antibodies, anti-A or anti-B. And we know that those are most likely of IgG subtype. We know that IgG can cross the placenta, and thus the baby will have anti-A or anti-B antibody in their body that can cause hemolysis. Okay? Usually, this doesn't affect the first baby in ABO incompatibility, okay, for two reasons or one reason. هلا اللي احنا حكينا during the pregnancy الفيتو maternal hemorrhage اللي بصير of very minimal amount، يعني الامount of RBCs that could leak من الفيتس to their mom is very small, and this is not enough to produce a strong immunogenic، ما بنسميها احنا not strong immunogenic، يعني it's unable to produce strong immune reaction. So the load or the levels of IgG produced is not so sufficient to produce hemolysis in the first baby. Okay? When the major fetal maternal hemorrhage, when does it happen? The major one? During delivery. So when the baby is delivered, significant amount of the baby's blood leak to the mom's circulation, and then after the baby is born, the mom immune system will start produce significant loads of IgGs, and these IgGs will, because of the memory cells, will stay vigilant and will stay in the mom's circulation. So on subsequent babies, if mom gets pregnant with a subsequent baby with A or B blood group, there will be a strong immune reaction to the RBC during pregnancy, even if the slightest RBC leaked to the mom through fetal maternal hemorrhage. This will produce hemolysis during pregnancy, okay, and sometimes babies can have hydrops fetalis. However, in ABO incompatibility, hydrops fetalis is not as common as in RH incompatibility, okay. Now, RH incompatibility, so when the mom is RH negative, so she does not express the RH protein, and the baby is RH positive, okay. So again, during pregnancy, you see fetal maternal hemorrhage, okay. And this will lead to the production of antibodies, okay. Sorry, أنا عكستهم صح. Sorry. ABO incompatibility can affect the first baby. It can. Sorry. Why? أنا أشرح. أنا حكيت عن RH. So sorry again. ABO incompatibility can affect the first baby. صح. الفيتو maternal hemorrhage is very minimal. بس شو اللي بصير؟ Our body, for example, me as a mom, is exposed to the A and B antigen expressed by bacteria. There's loads of bacteria بالenvironment تاعتنا. They express the A will be antigen. So my body as a mom will form in advance anti-A and anti-B, not due to fetal maternal hemorrhage, but due to my previous exposure through bacteria and other cause of exposure. So I will have sufficient amount of antibodies to produce hemolysis in the first baby. Okay? فهمنا؟ ما بدي أخربطكم. Okay, so ABO A can affect the first baby, A, number one, okay? Because of previous exposure to B and A antigen through bacteria and other sources, okay? And plus fetal maternal hemorrhage. So it can affect the first baby. This is not the case in RH incompatibility, because the only source of exposure to the RH protein is through the fetus, okay? ما في bacteria, for example, عليها ال RH, etc. So the only exposure for RH protein is through the fetus, and the fetal maternal hemorrhage during the first pregnancy is not able to produce a sufficient amount of immune reaction and sufficient load of antibodies, so the first baby is usually protected. But when the baby is born, the major fetal maternal hemorrhage happens and a stronger immune reaction happens, more load of antibodies will be formed, so the next baby will be for sure affected by RH hemolysis. That's why during the first pregnancy, if the mom is already known to have RH incompatibility, known to have RH negative, if she's RH negative, she on subsequent pregnancies should receive anti-D antibody. Okay, نعطيها anti-D to neutralize the antibodies اللي عندها, so that they don't pass to the baby and they don't cause intrauterine hemolysis. Okay, RH incompatibility, usually the immune reaction is much stronger than the ABO. So the babies اللي عندهم RH incompatibility, they are born with more deep jaundice, more severe hyperbilirubinemia, and significant anemia due to significant hemolysis. And RH incompatibility is able to cause hydrops fetalis much more than what the ABO incompatibility can do. Okay, فهمنا؟ في حدا لسه مخربط أو عنده سؤال؟ RH more. So the immune reaction with RH much stronger, okay? Hemolysis of the RBCs much more prominent, while antibody load is much more, okay? فمور hemolysis معناته more anemia معناته more jaundice, okay? الهيموليسيس والانيميا شو بتعمل؟ اللي هي subsequently رح تعمل high drops fetalis, okay? اوكي. حدا عنده اي سؤال؟ حدا متخربط؟ اه لا حنقول اي بي او يعني mother by default او. يعني اي بي او المام should be او، ما في اي بي او incompatibility والمام مش او. فهمت علي؟ عادي. لانه هي عندها شيز بي صح؟ يعني بي بوزيتيف، اوكي؟ والبيبي اي بوزيتيف. بس الام will not produce anti البيبي بلاد جروب. هلا الام ايش البلاد جروب تاعها؟ بي. طب والاب شو البيبي بده يكون؟ طيب يا اي يا بي. ما في اشي اسمه انتي، يعني ال RBC that express ال A antigen او اللي عندهم A او B they're unable to produce the antibodies against A or B. The problem is when you have neither of them. لما يكون ما عندك لا A ولا B يعني O. يعني حدا عنده blood group. سؤال، هلا اذا انت عندك blood group مثلا blood groupك تاعك A for example, okay, و for any reason انت صار عندك bleeding and you needed blood، شو بتاخد؟ ليش؟ تاخد A او طيب ما بتاخد B صح؟ مش فاهم السؤال. طيب الام بي. طيب كيف صار الطفل بي، كيف صار الطفل A والام بي؟ معناته الاب شو؟ مش فاهم. طيب معناته شو؟ برضه مش فاهم معناته. طب خلينا بعد محاضرة بنكتبها على ورقة بنشرحها. طيب لا راح اجاوبك بعد المحاضرة بس it's gonna take some time. طب خلينا نكمل نرجع لموضوع ال A وال B. هلا ال ABO incompatibility بتصير when the mom. هلا انت who's gonna produce الانتيبودي؟ الام. فهو should be exposed للانتيجين؟ الام. وهي ما عندها any of the antigens صح؟ طيب خلينا باخر المحاضرة نرجع لها باخر المحاضرة، بدناش نضيع وقت كتير عليها. طيب ال RH incompatibility بتصير بالسكند baby و moms who are RH negative should receive anti-D to prevent severe hemolysis and hydrops fetalis in the subsequent babies. Okay. طيب. Now another cause for hemolysis, you know it very well, G6PD deficiency. It's an X-linked disorder that mainly affects males unless there is lionization of the X chromosome in females. They can have, but if females do have G6PD deficiency, it would be much milder form than they would have. How does it manifest? They would have decreased levels of glucose 6-phosphate dehydrogenase. So this enzymes, it causes reducing energy to your cells, okay? And this reducing ability in our cells is very important for what we call an enzyme called NADPH, okay? NADPH, our cells need it because it helps maintain normal level of glutathione. Why do we need the glutathione? Glutathione is a very important antioxidant, okay? So it prevents RBC from being destroyed during oxidizing or stressful conditions like an infection, acidosis, etc. So kids with no G6PD, the net result deficiency راح يصير في عندهم abnormal glutathione levels. They don't have enough glutathione. وبالتالي during any oxidative stress their RBCs will hemolyze وبالتالي hemolysis, more heme production, more bilirubin, etc. The triggers تعرفوا triggers for G6PD mainly fava beans, some antibiotics like sulfa medications, infections, acidosis, stress, antimalarial medications, etc. طيب. Now, if you diagnose someone with طبعا G6PD, it should be screened because it's a very common disorder in our region, the Mediterranean region. So it's one of the diseases that gets screened بالheal prick test, okay? Babies who are very lucky are caught by screening, so their family is well educated about the possible stimulants for a crisis or hemolysis, okay? Now sometimes because it's a screening test يعني مش دقيق صح, it's not 100% precise, so some cases might be dismissed, and those who we see in hospital with crisis, hemolytic crisis, okay? Now, when you want to confirm they have, so you have a baby أو a kid عمره 4 سنين أكل فول إجانا بhemolysis, severe anemia, etc. And you want to confirm G6PD, we don't send the level during the crisis itself. ما بنعمل G6PD level because it will be falsely normal. ليش رح تكون normal؟ لأنه رح يصير في hemolysis of the RBCs ويطلع الانزيم, فإحنا measuring الانزيم level اللي بالdestructed RBC, ما عم نقيس baseline level of the enzyme. So we wait for the hemolysis to subside and then we send the level to confirm the diagnosis, okay? Crigler-Najjar syndrome, again, it's an autosomal genetic disorder in which there's a problem or a permanent deficiency in gluconeogenesis transferase, the enzyme responsible for conjugation. So they are unable to conjugate bilirubin, so we'll have unconjugate hyperbilirubinemia. It is 2 types. Type 1 does not respond to phenobarbital, and type 2 responds to phenobarbital, and type 1 is the more dangerous one, and it's a risk factor for connectitis. So babies usually they present with deep jaundice if they have Crigler-Najjar type 1. Gilbert syndrome, it's a much less common disorder. ليش much less common? ليش it's usually he مش less common, he underestimated or underdiagnosed Gilbert. Why? Very minimal symptoms. يعني هلا بجوز بالقاعة يكون عندكم مثلا واحد عنده Gilbert undiagnosed لأنه بيجي في very minimal symptoms. Yes. So the symptoms might be exaggerated during infection, stress, etc. But in a normal situation, Gilbert causes very mild hyperbilirubinemia. That's why it usually gets unnoticed or undiagnosed. Okay, breastfeeding jaundice. Breastfeeding jaundice, we discussed that in brief. ليش بصير in preemies, babies, preemie moms ما عندهم experience بالlactation, بالmotherhood, so they're unable to provide sufficient amount of milk to their babies, and this is actually very common. يعني تقريبا 13% of babies who are breastfed بصير عندهم breastfeeding jaundice. Okay. And we said it's mainly related to dehydration. Again, if you are dehydrated, ما عم put your body enough calories or enough food, the interior hepatic circulation will be prolonged, صح؟ لأنه nothing is getting in any way to accelerate the emptying أو peristalsis. The interior hepatic circulation will be prolonged. Again, more bilirubin will get the chance to go back and start the whole sequence once more. So more levels will be accumulating in the body instead of being excreted by stool. Clinical features, but you have to be aware of the jaundice itself and rule out the baby being very dehydrated, because dehydration can be a killer. However, breastfeeding jaundice will never kill a baby. It's dehydration that might kill babies, causing electrolyte imbalance. So you have to visualize or examine for dehydration signs. We discussed that breast milk jaundice is something different than breastfeeding jaundice. It's related to beta-glucuronidase enzyme presence in some mothers. يعني some mothers عندهم هذا الإنزيم in their breast milk, and this enzyme inhibits the proper conjugation leading to indirect hyperbilirubinemia. Okay. Now طبعا هذا النقاش دائما common discussion between doctors. No, this is okay. I'm feeding my baby very well. I give one feed every 2 hours. The baby is very well hydrated, but his breast milk. So okay, this is physiological breast milk jaundice. Stop breastfeeding. So this is the debatable part of management. For me, I never stop breastfeeding. So we always in medicine you weigh benefit versus risk, صح؟ وإحنا حكينا البريست milk jaundice هو physiological. It never goes beyond 12 in terms, never goes beyond 15, rarely in preterms, and it's very highly unlikely to cause kernicterus. احنا حكينا شو بنخاف من الجوندس mainly انه يصير CNS toxicity. تمام. because this can never harm the baby, why should I deprive the baby of the most important nutrients, specifically in the first days of life, which is colostrum, which is very rich in immunoglobulin. هلا كل all studies هلا they attributing childhood obesity, childhood diabetes, metabolic syndrome, some poor immune responses to deprivation of breast milk. Breast milk, it's called the liquid gold. Okay, so I would never ever tell any mom to stop feeding their babies. The most precious thing a mom can provide for her baby. So what we say, we just observe. Okay, we give the mom the red flag that she needs to look for. We know if the baby gets deeply jaundice, or jaundice is worsening instead of improving, because the baby might have an underlying pathology going on. The baby might be going through sepsis, صح؟ ممكن يصير في عنده sepsis هو أصلا عنده physiological jaundice, this can exaggerate this. We discuss the red flags: fever, hyperactivity, hypothermia, decreased oral intake, abnormal skin rash. Bring him back. Otherwise, just observe and feed the baby as much as possible. Okay? If physiological jaundice causes increased level of hyperbilirubinemia that needs treatment, we treat by phototherapy. So either شو modality of treatment for jaundice طبعا هي according to the cause. إذا عم نحكي عن physiological jaundice, it's phototherapy mainly. Okay? But this if the bilirubin level reaches a level where it needs to be treated, and there are specific curves that we follow هلا رح نحكي عنهم. Okay. Causes of direct or conjugated hyperbilirubinemia are mainly divided into hepatic, prehepatic, and posthepatic. Okay, hepatic cause, for example, infectious زي hepatitis. Okay, congenital infections زي torch infections, inborn error metabolism زي ما حكينا galactosemia for example, and tyrosinemia. Okay. Post-hepatic, the most common cause that you need to rule out is إجا عنا طفل عنده direct hyperbilirubinemia. أول إشي بنعمله بنقول rule out biliary atresia. This is the first thing that you need to rule out. So the single most important pathology that you need to rule out in a newborn with direct hyperbilirubinemia is biliary atresia, because it's a surgically corrected cause of fatality and morbidity, can lead to liver failure and then death. Okay, so biliary atresia needs to be ruled out as soon as possible بالإضافة ل other causes like the choledochal cyst and etc. Okay? How do they present? If a kid عنده post-hepatic أو obstruction, how would they present? احنا قلنا إذا في obstruction يعني bilirubin is not flowing out toward the intestine. صح؟ What gives your stool brown color? It is sterco. Okay? But if there is outflow obstruction of bilirubin, the baby will have clay-colored stool. Okay, the stool will be colorless. Okay, so dark urine, jaundice, clay-colored stool, and hepatomegaly. Okay. How do we diagnose? By this we mean biliary atresia. We diagnose biliary atresia. The gold standard طبعا اللي هي البيوبسي, but we do other things like HIDA scan. We call it HIDA scan. HIDA scan is a suggestive cause, but the gold standard is when intraoperatively. So intraoperatively is where we do the gold standard. We call it intraoperative cholangiogram. How do we treat? There's a surgical correction, which is basically اسمها كساي procedure. يعني ما في connection بين biliary tract والبول. You make that connection surgically, يعني connection عشان for bilirubin to flow out and gets excreted. The definitive treatment, so this is not a definitive treatment. This is not curative kasai. It's something to prevent liver destruction, okay, and liver failure. The gold or the curative treatment is liver transplant. Choledochal cyst, you don't need to know much about this. Okay. So classification according to onset. حكينا احنا we classify direct, indirect, physiological, pathological, according to the onset. So early onset حكينا the most common causes ABO, RH, and G6PD. Intermediate يعني البين بين مش delayed ممكن تكون anything basically this intermediate anything. Physiological, breast milk, breastfeeding, sepsis, hemolysis, torch, Krigler-Najjar, etc. Late, mainly biliary atresia, obstruction. Again, sepsis can cause late according to the onset of sepsis. بالنسبة للunconjugated late or prolonged breast milk. احنا حكينا physiological jaundice usually disappears by week 2. قلنا with an exception اللي هو breast milk. صح؟ Breast milk can extend beyond week 2 even though it's physiological. صح؟ لأن physiological by week 2 it's resolved except breast milk. The problem can extend. ممكن نشوف breast milk jaundice still apparent لحد شهر شهرين sometimes more. Okay. وما تنسوا لما نحكي jaundice يعني a level of more than 5. So the level could be 7, 8 يعني negligible. Okay. But it's still called jaundice لأنه more than 5 mg per deciliter. Okay, خلصنا عن neonatal jaundice. نحكي عن jaundice in children with some specification or extra information يعني. Jaundice in children. If a child presents to you with jaundice, أول إشي بيخطر بالك to rule out acute and chronic liver disease. Okay. So again, if it's unconjugated, it's either hemolytic or non-hemolytic. Okay, hemolytic تعمل usually mild jaundice in children. Hemolysis rarely causes abdominal pain, so it's usually painless jaundice. نسميه بالhemolysis. On examination, because RBCs are getting destroyed in the reticular endothelial system, babies would have hepatosplenomegaly. In hemolytic jaundice, stool color is sometimes can be yellower than normal لأنه more bilirubin is being excreted through stool. Urine can be variable in color according to the etiology, according to the depth or the severity of jaundice. Usually in hemolytic diseases لازم تسأل عن family history. Any family history of blood transfusion, any family history of G6PD, any family history of hemoglobinopathies or any problems, spherocytosis, etc. Because there's destruction of RBCs, the bone marrow will be alert to produce more RBCs. For reticulocytes, our immature RBCs level will increase in the peripheral circulation. Okay. Again, hemolytic anemia causes indirect hyperbilirubinemia. If it's hemolysis, then the liver is fine. ALT, AST should be normal. The transaminase enzyme should be normal. Okay. Now, there's hemolysis. شو بدي أعمل? We do COOM. صح؟ هلا if COOM test is positive معناته autoimmune زي شو؟ يعني في antibodies بمعنى آخر. Our body is producing antibody for whatever reason. هذول antibodies are attaching themselves لل RBCs and facilitating its destruction. زي what we see in autoimmune hemolytic anemia in ABO and RH incompatibility. Systemic lupus erythematosus بصير في production of autoantibodies against circulating autoantibodies or sometimes it's drug induced. Okay. If it's negative, so it's not immune mediated, most likely this is enzyme related. يعني زي G6PD deficiency for example أو abnormal RBC shape, globulopathy, ptosis إلى آخره. Unconjugated bilirubin or indirect bilirubin, so non-hemolytic causes like Gilbert syndrome, Krigler-Najjar, and hypothyroidism. As I said, hypothyroidism, you will read the cause in both direct or indirect. Okay. or if there's internal hemorrhage, as we said, cephalohematoma or other sources of hemorrhage or blood collection. Okay. Again, conjugated hyperbilirubinemia or direct. So the cause is hepatocellular. يعني hepatocytes are not doing very well producing a conjugation enzyme, or cholestatic. يعني everything is fine with the hepatocyte, but it's the outflow of bilirubin that is threatened. ما رح نرجع نعيدهم. Anyway, hepatocellular jaundice يعني there is a problem with الهيباتوسايت. ممكن يكون السبب infection, injury. صح؟ يكون ال ALT وال AST elevated. The baby is jaundiced. Urine color is very dark. If it's hepatocellular jaundice, can I see pallor or pale stool? Well, this is according whether the underlying pathology includes stasis or outflow obstruction or not. Okay. Again, hepatocellular jaundice can be caused by infection like hepatitis, either viral hepatitis or like hepatitis A, B, C, D, E, or other viruses like CMV, EBV, HSV, and adenovirus, bacteria like typhoid hepatitis, tuberculosis hepatitis, etc., or protozoal like malaria. Okay. Drugs that can cause jaundice are many, like acetaminophen, like paracetamol, salicylate, iron, phenytoin. So anti-epileptic medication, most of them can cause jaundice or hyperbilirubinemia. Metabolic causes, many metabolic disorders can cause jaundice, like Wilson, galactosemia, which is direct hyperbilirubinemia, glycogen storage disease, tyrosinemia, alpha-1 antitrypsin deficiency, which is very uncommon but can cause multisystemic involvement like pulmonary, hepatic, etc. حكيناهم الكوليستاتيك jaundice. So, how to approach neonates and children with jaundice? Okay. Now, confirm it is jaundice أول إشي. على physical exam نطلع how deep the jaundice is. Is it only the sclera? Is it only the face? Does it go down to the trunk, lower extremity, or no? What symptoms does the baby have? Is he febrile? Does this indicate there's an underlying infection or sepsis that's causing jaundice? Is the baby active? Is he well hydrated? Is he able to feed or not? Abdominal exam, is there any hepatosplenomegaly? Is the baby anemic? Does the baby look anemic? Signs of anemia, signs of hemodynamic instability. We ask about stool color, urine color. We ask about, as we said, family history, hemoglobinopathy, similar problems, previous newborns with similar condition, other children with jaundice or hepatic diseases or hematological disorders. Again, if there's fever, نعرف إحنا بنعمل analysis للفيفر صح؟ اللي هي when did it start? How bad is the fever? Is it responsive to antibiotic or not? Is it associated with chills and rigor or not? We think of hepatitis specifically if there is ill contact, for example, in children, if there is outbreak locally in school, mosques where they pray, in the family itself or no. History of any medication, and we discussed drug-induced hyperbilirubinemia. Could it be cholecystitis? Yes, some kids can develop cholecystitis. On physical exam, we check for the right subcostal or costophrenic angle, right subcostal tenderness as a sign of cholecystitis in kids. Hypochondral pain. Okay. So what signs do we need to tackle or look for? We said activity, is the baby hydrated, dehydrated, how deep the jaundice is, signs of anemia, hepatosplenomegaly, any evidence of weight loss, wrinkly skin, folds, very loose folds, skin folds which indicates weight loss, any thermal instability, any evidence of trauma or injury that caused internal bleeding and blood hemolysis and then jaundice, any evidence of kernicterus and newborns like seizure, abnormal movement, spasticity, etc. سوري. طيب هلا احنا لما نطلع على الساينز اوف بالر وين بتطلع انت؟ So palmar creases, okay. Yes, it's difficult, yes, sometimes to appreciate that the baby is very anemic when he's jaundiced, خاصة is deeply jaundiced. But you can still tell if it's severe pallor, it can still be appreciated. If it's just mild pallor, yes, it can be dismissed, okay? But if it's significant, you will be able to appreciate it. هلا, if there's significant anemia that's causing significant pallor that you can see, the baby will have other symptoms, صح؟ رح يكون في عنده مثلا poor exercise tolerance, رح يكون في عنده fatigability, رح يكون في عنده shortness of breath, رح يكون في عنده tachycardia, يعني signs of hemodynamic instability, okay? طيب هلا clinically how do we assess or judge jaundice? There is a Kramer scale, احنا بنسميه Kramer scale اللي هو to estimate how bad or how deep the jaundice is. So this is dividing the body into zones. So usually if only the neck and above, يعني face is affected, it's unlikely to go above 5, okay? So if it's up to 5 بنلاقيها الفيس والneck but it doesn't go below this, alright? Now if it's reaching the trunk, يعني الbody, chest, upper abdomen or trunk, the level is more than 5 but يعني less than 10, okay? So again, neck and above unlikely to be above 5, so I wouldn't panic. يعني إذا حدا عمره أسبوع وجاي ب jaundiced face, I wouldn't panic, okay? If the baby is 2 days old and the jaundice is reaching the trunk, the chest, the abdomen, this is up to 10, so the baby might need, will need actually, إذا عمره يوم, will need phototherapy for treatment. If it reaches further down, so lower abdomen, pelvis area يعني with thighs, this indicates إنه the level is above 10 but below 15. If it goes down to the legs, it's above 15. And if it down to feet, including the palms with sole, this is severe jaundice, can reach up to 20, okay? On physical examination, in addition to what we mentioned and when we examine neonates, دائما look for signs of hepatic disease. Like what? By مثلا كنا نقول بالintroductory by inspection بتطلع على spider nevi for example, بتطلع على dilated veins. While I'm sitting beside the baby I check for abnormal smell like fetor hepaticus مثلا. بدي أطلع إذا في tremor, صح? Coarse or flapping tremor that can indicate underlying biliary or hepatic problem. يعني هالأشياء added to what we know when we examine neonates, we have to examine it as well in children. طيب investigations for conjugated bilirubin. So إذا عم نحكي عن newborn بالإضافة للliver function test بنعمل مثلا hemolytic profile, صح؟ بس إحنا لا sorry إذا conjugated بدي I have to rule out sepsis can cause conjugated, بدي I have to rule out thyroid disorder, I have to rule out metabolic disorders like galactosemia for example. But I need to send a whole lot of tests بالconjugated hyperbilirubinemia. Metabolic screen, torch profile, liver biopsy sometimes needed. HIDA scan, as I said, with direct, newborn and direct, always rule out biliary atresia. So HIDA scan is essential. Ultrasound للbiliary system عشان نشوف هل في واضح مثلا في dilated مثلا biliary tract or no. Coagulation profile is very important because the one cause of direct hyperbilirubinemia is liver disease that can cause with time coagulopathy. لما درسنا الcoagulation مثلا cascade, many factors بالcoagulation are produced by the liver, صح? If the liver is diseased or في any underlying hepatic pathology, there might be coagulopathy وبالتالي bleeding tendency. فبنبعت the bleeding profile PT, PTT, INR, liver enzymes, thyroid function. بالunconjugated بيكون my thinking is shifted to another يعني way. بدي أعمل CBC blood film أشوف ال RBCs شو حجمهم شو شكلهم بالبلد فيلم, هل في spherocytosis ما في spherocytosis, هل في sickling for example ما في sickling. Yes, I would need to check for the retic index or the retic count. I need to know the maternal blood group and the baby blood group. Direct comb test to rule out immune-mediated hemolysis versus non-immune-mediated. Okay. So how do we treat? If it's indirect, so I'm not now dealing with a hepatic disorder or hepatic disease. I'm not dealing with a thyroid problem. I'm not dealing with metabolic disorder, for example. أول إشي يجي علينا ب indirect, unconjugated. Make sure that the baby oral intake is optimal, feeding is optimal. If the level is reaching a specific level that needs treatment, we need to treat with phototherapy. Sometimes if it's immune mediated, يعني there is significant antibody production causing significant hemolysis. The jaundice will get worse with time as long as there's ongoing hemolysis. So we need sometimes to give intravenous immunoglobulin, okay, to saturate the binding sites على RBC, to prevent the autoantibodies from binding and causing destruction. And eventually if we fail to do so إذا استخدمنا هدول modalities عملنا phototherapy أعطينا IVIG but the baby is deteriorating, the hyperbilirubinemia is getting worse, we need to do exchange transfusion. Simply by exchange transfusion باخد الدم تاع البيبي بيعطيه دم تاني من donor, okay? زي as if I'm washing out his body من circulating antibodies, okay? If it's conjugated, you need to treat the underlying problem. يعني a newborn, first thing rule out مثلا biliary atresia. إذا في biliary atresia البيبي بده كساي procedure بده liver transplant. Okay, this is how we do phototherapy. So in phototherapy, الفكرة of phototherapy إنه the baby is exposed to a specific light, so not any light. This is one of the common questions للأهل. Can I put him under a light in my room? No, this doesn't work because the light should be in a specific wavelength. 470 children should range between 420 and 470, and this is the main idea of to form water soluble isomers, photoisomers, okay? يعني أنا عم بحول البيليروبين ل water soluble form عشان to facilitate its excretion. So this is the idea of phototherapy. ما بنفع السانلايت، لا السانلايت بنفع ولا الضوء العادي بنفع. هلا دائما بيحكوا لك بالكتب الستديز sunlight exposure is good. In some studies بقول لك it might help. However احنا بنخاف انه الام تترك ابنها تحت السانلايت نرجع نلاقيه عنده burn، نرجع dehydrated، ناشف الولد، okay? ف some studies بيحكوا after proper therapy in patient if the baby needs that and the baby is discharged home you can provide sunlight exposure not direct light يكون جنب الشباك مش تحت الشمس مباشرة for 10 minutes at most يعني per day, okay? طيب when do we start phototherapy? Who needs phototherapy? This depends on the level of bilirubin, the onset of hyperbilirubinemia. لأن حكينا في specific curves نطلع عليهم. في curve اللي هو level والage. مش كل level بيحتاج phototherapy حسب شو level in comparison to the age, okay? هلا شو يعني؟ The threshold at which the baby needs phototherapy increases with age. يعني a baby هلأ born رح يحتاج فوتوثيرابي إذا البيليروبين عنده 5 تمام، بس إذا جبت بيبي عمره 5 أيام والبيليروبين عنده 5 ما رح يحتاج عليها exchange، ما رح يحتاج عليها فوتوثيرابي. So the same level التريتمنت تاعتها اختلفت حسب الage. So the main limiting factor اللي هو الage of the baby. طيب هاي الكيرف اللي حكيت لكم عنه، أوكي؟ هلا الكيرف بيعتمد هذا كيف بمشي عليه حسب الليفل والايج والريسك فاكتورز. بنقسمهم ل low risk, moderate risk و high risk. شو يعني low risk؟ يعني the baby is a very low risk for example to develop kernicterus, a very low risk to develop يعني to have accelerated hyperbilirubinemia. معناته I will be more cautious, I will be less cautious بهذا البيبي لأنه he is very low risk ما بيخوفني. يعني إذا بحتاج فوتوثيرابي أوكي بنعطيه فوتوثيرابي بس الثريشولد بتكون عالية. إذا ما بحتاج فوتوثيرابي و discharge home. هلا كيف نطلع على الكيرف؟ طيب شو هم الريسك فاكتورز؟ هلا البيبي البريماتشور اللي هو عمره اقل من 38 ويك هاي one risk factor. اوكي. اذا البيبي عنده hemolysis يعني انا شخصته انه عنده hemolytic ongoing hemolysis due to ABO او RH, this is another risk factor. اوكي. اذا البيبي is septic again this is a risk factor. اوكي. طيب مين هم اللو ريسك؟ شايفين اول خط تحت؟ اوكي. طيب طلع هذا هاي ريسك اللي فوقه ميديوم، اللو ريسك اللي هو فوق اخر اشي. شايفين الثريشولد كيف زادت لنفس الرقم؟ طيب لو ريسك هو حكينا اي طفل عمره فوق 38 gestation week يعني 38 week gestation plus وما عنده other risk factor، ما عنده sepsis، ما عنده hemolysis، ما عنده any other risk factor. فمثلا بتطلع انه هون كان عنده مثلا البيليروبين 5. اوكي. هون وهلا قديش عمره؟ مثلا نفرض عمره قديش نقول يوم، برسم خط بين اليوم والليفل 5 وبشوف لواحد عمره اللي عنده لو ريسك هل هو الماشي يعني هل هو سوري مش عارفه اشرح لانه مش عم بوصل للماوس ببين. لا وين؟ لا هذا البوينتر ليزر هات. طيب يلا خلاص زبطت. اوكي. طيب انا عندي بيبي عمره 24 ساعه. اوكي. عملت له بيليروبين ليفل وطلعت عندي الليفل فور اكزامبل 10. تمام. عمره 24 ساعه وانا قررت انه البيبي لو ريسك لانه هو فول تيرم وما عنده اي ريسك فاكتور. طيب هاي عمره 24 ساعه وعنده 10 بطلع بخط هاي 10. انا above الكيرف above على اي ليفل بيحتاج اللي هو الليفل اللي التقت بين 24 والخط. على اي ليفل بيحتاج يعني بيحتاج فوتوثيرابي هون تقريبا على 12 تقريبا يعني هو عنده 10. شو يعني هلا ما بده فوتوثيرابي. هلا هذا الطفل لانه بين 10 و12 يعني حد صغير، فيا اما بقول للام روحي وبرجع بعيد التست بكره او بعد بكره اشوف is it increasing trending up trending down او زي ما هو، او بعطي الام اذا انا الام بعرف انها educated مثلا دكتوره بحكي لها مثلا راقبي انت شو بتحسي ساينز على طريق الكرامر سكيل. هل الجوندس ضل بنص التشست؟ هل نزل لاخر الابدومن والثايز معناته اكثر من 10 معناته بدك ترجعي. اوكي الى اخره. اذا البيبي طيب مولود 37 ويكس برضه نفس هذا البيبي عنده عمره 24 ساعه. هيو 24 ساعة بس هو مولود 37 ويكس يعني صار مودريت ريسك عنده 1 ريسك فاكتور مودريت ريسك صح يعني بالنص. فهذا الكيرف تاعه على 24 ساعة بيحتاج فوتو على 9 هو عنده 10 فهذا البيبي بده ادميشن. يعني الفرق بعمرهم اسبوع بس، واحد روحته على البيت وواحد دخلته في الفوتوثيرابي. شفنا كيف الفرق بالمانجمنت. سو ات مينلي ديبندز مش بس على الليفل على الايج. اوكي. اذا البيبي مولود 37 ويكس ودخل عندي البيبي هايبو اكتيف وعملت له سي بي سي وسي ار بي الانفلاماتوري ماركرز هاي فهي في عنده ongoing diagnosis of sepsis صح. فهذا صار هاي ريسك بيبي. هاي ريسك بيبي شوفوا الكيرف هيو عمره 24 ساعة مثلا نفس العمر بيحتاج اني ادخله فوتوثيرابي على ليفل 7 فالثريشولد صارت اقل. اوكي. ايش؟ لا هاي الكيرف اللي بعد شوف هلا بعد ال7 دايز صاروا الكيرفات كلهم ثابتين ما عم بزيد ولا عم بنقص. مو فاهمه. هلا هدول الكيرفات مش للاطفال. تمام. هذا الكيرف للنيوبورنز بس ريسك ستراتيفيكيشن فور نيوبورن بيبيز بس. بعد ال7 دايز حتى اكشلي بعد ال5 دايز بتطلعوا على ال5 دايز اذا بترسموا خط كل الكيرفز they go through plateau يعني راح يضلوا المانجمنت سيم ما راح تغير. اوكي. طيب بيلي بلانكت هذا اشي يوزد يعني مش عنا بالدول برا. اذا انت you don't want to admit the baby مثلا البيبي الاهل ما بقدروا يدخلوه insurance problems الهوسبيتال is full الاهل ما بدهم admission الهوسبيتال يعني هو بيعطينا similar wavelength light with similar wavelength بنلف في البيبي for specific hours per day مع سيريال بالروبين تشيك بالهيلث سنترز. طيب هلا اذا عمركم فتوا خداج او شفتوا حدا بيبي بالخداج عم بياخد فوتوثيرابي دائما بيكونوا we make sure انه الجينيتال area is very well covered والايز دائما عليهم cover. اوكي الايز should be covered والجينيتال area should be covered لانه phototherapy itself and newborns with very such sensitive skin they have risk to develop retinal damage, so that's why you never expose their eyes, and testicular injury that can threaten their fertility. Okay, so a baby can become infertile because he was treated with phototherapy without covering their private area. Okay, skin burn because it's light exposure for a prolonged period of time. فممكن يصير عندهم skin burn, what we call brown baby or bronze baby syndrome, and they can go through dehydration. إنه رح يزيد ال insensible losses لأنه هو light wavelength it produces temperature صح؟ رح يصير عندهم insensible water loss or dehydration and dermatitis in some children or hypersensitivity reaction. So this is how a baby looks like bronze baby syndrome. كيف صار skin color. طيب حكينا last resort إذا baby جربنا مثلا عنده hemolysis ongoing hemolysis جربنا phototherapy وجربنا نعطي IVIG بس the baby is not responding. The last resort would be to do exchange transfusion. It should be done through a central line مش peripheral cannula, يعني لازم يكون في central line. When they are born بتكون نسميه احنا row umbilical stump, يعني الامبليكس تاعتهم still row. شو فيها الامبليكس؟ فيها 2 arteries وفيها 1 vein صح؟ فبنستخدم الفين to insert umbilical venous catheter. اوكي تمام. فبعطي البيبي blood while I'm taking out his blood. Okay, this is to exchange his blood to wash out circulating antibody and to stop hemolysis. Why is it حكينا احنا the main reason to why we panic لما يكون البيبي is deeply jaundiced والbilirubin level is very high لأنه they have a risk for to develop kernicterus. Kernicterus يعني permanent neurological sequelae, يعني رح يضل عنده problem. اوكي طيب هدول side effects احفظوهم لل exchange transfusion. طيب قلنا one of the modalities أن نعطي IVIG to يعني saturate receptor or binding sites على RBCs عشان تمنع ال other autoantibodies from attaching to the RBC and destroying them. home remedies against sun exposure شو حكينا عنه maximum 10 minutes per day, not direct sunlight, ونكون very vigilant to signs of hyperthermia كمان with dehydration. Never give a baby water with sugar. هاي الأمهات الكبار الجدات بيعملوها يعطوا مي وسكر. This is very wrong. The baby can go through electrolyte imbalance and kidney impairment. Garlic, بحطوا necklace of garlic. This is a myth and it will not work. عندهم في عندهم الناس القرويين عندهم برضه they still believe in these myths, يعني الجارليك وال water and sugar. طيب احنا حكينا عن التريتمنت. So احنا قلنا المين reason we want to prevent الكارنكترس اللي بيصير بالبيبيز عندهم indirect hyperbilirubinemia, indirect unconjugated يعني lipid soluble, so it can cross the blood-brain barrier and cause problems. Okay, so the risk for to develop kernicterus when bilirubin reaches a level of more than 20, usually 25 and above. Okay, it's a very preventable cause of mortality and morbidity. Out of 10 kids or out of 100 kids with kernicterus, 10 would die and 70 will have permanent sequelae. Okay, so if a baby develops kernicterus, they go through stages of phase 1 when the baby is very hypotonic, very lethargic, poor sucking, weak cry, or high low pitch cry. And then with time, after 7 days to 10 days, they go through phase 2, which is hypertonic. They are very stiff, hypertonic. The tone is increased and they start to express opisthotonus. انتوا شايفينها هلا بالصورة. Phase 3, the hypertonia will start to improve. They will develop high pitch cry. They will be very irritable. دائما في البيبي is irritable crying, high pitch cry. This will lead to sometimes in some kids visual loss and hearing loss. Okay. These are the neurological manifestations for connectors: chorioathetoid cerebral palsy, upward gaze palsy, sensory neural hearing loss, and of course intellectual disability. We mentioned also the treatment of connectors. So treat the underlying cause for hyperbilirubinemia, prevent this from getting worse. Okay. You need to counsel the family about connectors and its sequelae, خاصة neurological sequelae. They need to cope with it. And this is a catastrophic, يعني dramatic thing to tell them. تحكي لهم إنه your child might die, and most likely 7 out of 10 he will develop permanent neurological sequelae. And most times they do develop permanent neurological sequelae. So this is a devastating news for them. So you need to adapt. وهذا الشيء طبعا مش موجود عندنا التريننج وكونسلنج. احنا بنعطي الدياجنوسز وبيروحوا الاهل للاسف to deal with it on their own. زي ما حكينا الكيدز will have feeding difficulty. دائما عندهم opisthotonus و abnormal posture. They're very irritable. Sometimes they need NG tube feeding. So you have to make sure that they have optimal feeding modality. Because they develop limitation بالmovements, hypertonic, they need physiotherapy and physio and occupational therapy. This should be done as well. Speech and language therapy, which is called SALT, is very important as well. حكينا part of them will develop sensory neural hearing loss. Some of them will have intellectual disabilities and they need to go and be admitted to special care schools, which are lacking here. And that's it.